The upcoming panel features highly respected cardiologists known for their innovations in cardiovascular risk modification and advanced heart failure management. Dr. C.G. Sajeev, Dr. Philippos John, Dr. Manikandan TV, Dr. Sadat Pareed, and Dr. Iqbal PT. Respected dignitaries, we welcome you to the dais. May I invite our speakers, Dr. V.L. Jayaprakash, Dr. Girish PV, Dr. Praveen S. and Dr. Joby K. Thomas to please proceed to the stage and take your designated seat on the dais. Respected chairpersons, the stage is yours.
Dear chairs, teachers and colleagues, thanks to the scientific committee. The topic which I am going to touch upon today within this limited time is intensive lipid lowering therapy in cardiovascular diseases. We all know that LDL is an independent risk factor for the atherosclerotic cardiovascular disease, and right from the early days we have a lot of data with a large number of patients, and the NCEP in 2002, the risks, according to the risk, the levels were of the LDL were 160, 130 and 100 depending on the risk. In early 2000s, we came to two important trials, that is TNT and PROVE-IT, where the levels went further down. In the TNT, it was 77, and we can see that both the primary endpoint as well as the secondary endpoints were significantly lower in the high-intensity statin group, where the cholesterol levels or LDL levels were to the tune of 70. And PROVE-IT, it went further down to 62. There also, all the outcomes and the key secondary endpoints were lower compared to the more lipid group. This was supported by other trials like IDEAL, Heart Protection Study Search, and REVEAL. Then we moved to 2017-18, we had two important trials with PCSK9, one was on Avelumab, that is a Fourier trial, and Alirocumab, the Odyssey outcomes trial. And what was the thing? It was the median LDL was 30 in the Fourier trial, and in the Odyssey it was 40, much lower than the previous concept. And let us see the results. The primary and also the key secondary endpoints were significantly lower in both the groups, 30 LDL group and 40 LDL group, both in the Fourier and Odyssey outcomes trial. So based on this, currently the CSI 2019 brought out this. The LDL level should be less than 55 in a patient with very high risk, both for primary as well as secondary prevention. And it should be less than 40 in a patient, that is class 2B recommendation, who had a second vascular event within 2 years. And probably for the high risk, it is less than 70, and for the moderate risk, 100, and for the low risk, it should be less than 160. This was the 2019 ESC recommendation. What about going further? We had trials after this, two newer trials where it went even to 30. That is a Sparkle trial where it was stroke and TIA was addressed. There was significant reduction in the MACE. And also GLAGO trial, which is a primary and IVOS trial, it showed that even up to 20 LDL, there was a steady regression in the plaque volume, the atheroma volume, as well as an extension showed that there was a decrease in the composite endpoints of death, myocardial infarction, stroke, and need for revascularization in hospital as low as 20. Even in patients above 30, that was reduced to 20. And the concept on hit hard and hit early came subsequently, which showed that, especially in ACS, we had to hit hard and hit early. And one of the important data which came after this was the Fourier open label extension trial, which was 8.6 years follow-up with Avelumab. And one can see 25% of the patients who are in this group, less than 20 was the LDL. And what about the outcomes? It was significantly astonishing. All the outcomes, cardiovascular death, the MACE, the composite MACE, and individual primary endpoints, all were significantly lower as you steadily go down from 70 to 20, and even in 20, less than 20, it was significantly lower. Look at the graph. This was a 20 group where there was a steady decrease in the MACE, even less than 20 LDL. But we were concerned on the risk, new onset diabetes, hemorrhagic stroke, cataract, and cognitive decline. What about that? Two important trials addressed this. One was the Osler, and a very recently published Ebbinghaus, which is a subsidy of the Fourier trial, which showed that there was no concern on the cognitive dysfunction. All the aspects of the cognitive function was assessed that was not at all different. And what about the outcome? This is the safety outcome levels. Nothing. Neurocognitive, cataract, malignancy, diabetes, hemorrhagic stroke, nothing was higher in the low LDL group. And recently published meta-analysis, not only Fourier, a lot of trials has shown that it is going lower, even up to 21 milligram per deciliter. There was a consistent reduction in the MACE rates. So based on this, the CSI has brought the 24 guidelines where low risk, it should be less than 100, and moderate risk, it should be less than 100, high risk, it should be less than 70, and very high risk, it should be less than 55, and extremely high risk, it should be less than 40. And even the Lipid Association India has brought out that if it is a category B with a high risk, with these features, it should be less than 30. And this was the current management guidelines. Based on this, hit hard and hit early in an ACS. 80 milligrams of atorvastatin plus ezetimibe within 24 hours, 4 weeks repeat. If it's more than 55, add bempedoic acid. If it's still more than 55, you can try with PCSK9, and it has to be less than 55. And as I told, less than 45 in the extreme high risk group, and probably less than 30. And in stable also, you have to be less. It is 40 milligrams of atorvastatin, same levels. More than 55, add ezetimibe. At 8 weeks, if it's more than 55, one can go for higher dose, and then one can think of other non-statin therapies. So where are we? There is a consistent relative risk reduction in major vascular events per further reduction in LDL as low as a median of less than 20, with no offsetting adverse effects as shown in all these trials. And I would like to tell that it was single digit in around 10% of the patients. It was 7 was the mean LDL. Risk is often underestimated. Another point. We don't properly look at the risk assessment of the patient when we start the statin and continue on the LDL management. So risk often is underestimated, and more sad is that only 20% of the dyslipidemic patients are managed as per the guidelines. And the concept of hit early and hit hard has come. Especially in ACS, we have to hit early and hit hard. And probably I would say low, lower, and lowest is better. Thank you.
Thank you. Questions, I think we'll take it in the last part. Next topic is ticagrelor monotherapy is good enough. Time to do away with aspirin. Dr. Girish.
Respected Chair, friends, senior teachers, colleagues, it's my pleasure here to stand as part of CSI team for this topic here. And there's a hot debate topic. I think Dr. Sridhar had put some light with the latest trials, also putting insight on this aspect of ticagrelor monotherapy. Is it time to do away with aspirin, or rather the ideal time to take away aspirin would be a better frame of words? Because always the challenge for the interventional cardiologists is that when they deal with risky patients who are simultaneously at the risk of high bleeding as well as ischemia, it's always the challenge to find that sweet spot where you do not take away the drugs prematurely, that you end up in high MACE due to the premature taking off of the DAPT. That is the challenge. And especially with the complex substrate of diseases that we now deal with, and in the elderly population, this becomes a question of can we get long-term benefits with single antiplatelets, stronger antiplatelets without aspirin. So conceptualizing the progress of ischemic and bleeding risk in ACS with time, it is seen that the maximum point of the ischemic and bleeding phenomenon often collide within the first 24 hours. But proportionately, you see that the ischemic risk rapidly comes down with revascularization, but the bleeding risk kind of increases over the first 24 to 48 hours or so, and it takes a while to come down. And this bleeding risk declines more rapidly than ischemic risk though, but it's probably crossed over the first 2 weeks, and the first 1 month would be a critical point in this phase. And in the long run, the persistent ischemic risk is definitely a phenomenon that is always a cost. But then the question is whether this decreased ischemic risk necessarily comes at the cost of a higher bleeding risk. Could aspirin-free OAP strategies be an alternative strategy? And what is the rationale for aspirin-free strategies? And that is what we are trying to discuss here. And among the options that we already have tried and tested are situations where you have high thrombotic and a high bleeding risk, where we are forced to reduce the duration of DAPT to a very short period, like a month or 3, based on a few trials, which I'll just try to go about. And that personalization would probably be the best way to do it. And why aspirin has been a cornerstone of ACS management? Because it probably came first, and most of the trials had been tested with an aspirin background, and hence the studies were all related in that way. But looking at the physiological point of view, the platelet function studies, when you have stronger antiplatelets like prasugrel or ticagrelor, it's actually seen with the additional benefit of there is little or no additional platelet inhibition with aspirin in the presence of potent P2Y12 inhibition. So the word potent is also important. And looking back at the Plateau trial itself, it was seen that in fact the groups with the lower aspirin had actually done better when ticagrelor was the drug along, because probably it has an interference with the ticagrelor's action also, mechanistic interaction. In fact, that is supposedly related to the ability of ticagrelor to inhibit cytokine release, which may be impeded when you have aspirin along, and the inflammatory aspect of not just the antiplatelet, the inflammatory aspect of atherothrombosis treated better with ticagrelor alone, it seems. And that was the idea of actually having a lower maintenance therapy. So what do you have the evidence? The major evidence comes from this Twilight study. That's the ticagrelor monotherapy, but this is at 3 months from PCI. And mind you that this STEMI was not a part of this. It was basically ACS, also unstable angina, and there was a stable CAD substrate. And here it was after 3 months of DAPT, where the patient tolerated, and in fact, it had complex subsets also. And the major factor that was looked into the BARC bleeding aspects more than the key secondary endpoints, which were composite all-cause death, non-fatal MI, stroke during the next 3 to 15 months. So what does the study show? It shows that ticagrelor monotherapy after 3 months versus ticagrelor DAPT significantly reduced bleedings while preserving the ischemic. So you can see the curves here touching each other with regard to the ischemic benefits, and the divergent curves, that is 7% in the bleeding risk in the combined arm versus ticagrelor monotherapy had 4%, and that contributed to a hazard ratio reduction of almost 44% in the overall trial. Subset analysis of the Twilight ACS, in fact, further show the ACS means the more thrombotic and more bleeding risk there. The monotherapy actually after 3 months, 53% reduction. So more robust benefit was demonstrated. Going further on the stent-based, the different types of stents were studied. So it is not, regardless of the stent type, this benefit prevailed in the Twilight stent sub-analysis of this trial. And Twilight complex is the complex analysis of the complex PCA substrate of ticagrelor monotherapy, reducing bleeding by close to 46%. Numerically lowered ischemic events simultaneously. So you did not trade off the bleeding risk for the ischemic risk, the simultaneous protection. And why the specific analysis actually showed that the Twilight thrombogenicity at the platelet endpoint, ex vivo thrombus area, was not much different when you have these two drugs. So you are not really taking down much by taking away aspirin regarding the thrombogenicity. And this other small trial is the TICO trial. Here the interesting part was that this included patients with STEMI. So you have data from STEMI also with this aspect, whereas the non-STEMI data was already there from the Twilight study. And they in fact have a combined analysis, the Twilight and TICO combined pooled analysis, the meta-analysis, where they have showed that there is 63% reduction of major bleeding risk with ticagrelor monotherapy with uncompromised efficacy. Uncompromised efficacy in the sense that there is not much difference between the statistically significant difference between the major adverse events were not seen with regard to the ischemic endpoints. And ticagrelor monotherapy probably trunks over the alternate strategy. So there could be, we could conceive of alternate strategies. Like for example, the P2Y12 inhibitor could be prasugrel or could be clopidogrel. But then the data is clearly in favor of having the smartest reversible ticagrelor like drug for this monotherapy, as at least for regard to the bleeding reduction as well as simultaneously having the protection. And so even in relatively high bleeding risk patients with simultaneously high risk for thrombotic events, we may be able to actively use this drug for select cases like even with renal disease where both risks exist, and though you have to be careful a bit. So what does this all lead to? The ticagrelor is only the only P2Y12 that has proven benefits is monotherapy, and that's what has come out with Twilight, and hence the guidelines are slowly evolving towards this approach. They are slowly recommending ticagrelor monotherapy, especially the ACC, AHA in ACS with who tolerated DAPT with ticagrelor, transition to ticagrelor monotherapy more than 1 month post PCI is a useful strategy to reduce bleeding risk. And in high bleeding risk, it's known already that aspirin or P2 inhibitor monotherapy after 1 month of DAPT may be considered. It is class 2B, but when it is ticagrelor, you have a class 2A recommendation that you may give a single antiplatelet for a longer period. And just finishing off, Ultimate DAPT is the other trial which also gave insights into this aspect. But here the DAPT was only 1 month duration. This is the latest trial where again MI patients were almost 30% of the trial. In summary, choice of antiplatelet therapy personalized to patient needs is crucial to achieve the sweet spot, and balancing the ischemic risk and bleeding is always a challenge, but dropping aspirin may allow ticagrelor to exert greater benefits and reduce the ischemic risk while also reducing the bleeding risk. Short-term DAPT with de-escalation of ticagrelor monotherapy probably is the way forward for most of our difficult substrates. Thank you.
Thank you, Dr. Girish. I think questions we'll take later. LV function assessment, time to end LVEF criteria. Dr. Praveen, please.
Good morning, chairpersons, teachers and friends. The topic is LV function assessment, whether it's the time to end the LVF criteria. Ejection fraction has come into existence by the year 1916, and the Dr. Stuart Bartle was he's the one who coined the term ejection fraction. And when Milton Packer, who has seminal articles regarding heart failure, met him, what is interesting is that this Stuart Bartle transformed from cardiology to, he changed his profession to psychiatry. And when he met, what he asked us, I asked him about his work on ejection fraction. Bartle rolled his eyes. It was a silly idea, he told with a twinkle. And that is why it was his time to specialize in psychiatry. So that is a position of ejection fraction as per the author who coined the term ejection fraction. Calculation of ejection fraction can be from M mode echocardiography, B mode echocardiography, or even three-dimensional echocardiography. And it's a widely used echocardiographic parameter for evaluating cardiac function. And ejection fraction, as you know, it's simply in terms of stroke volume and diastolic volume. And the current guidelines recommend the biplane method of summation, or the modified Simpson's rule. This is a recommended 2D method to assess ejection fraction. Just because it is simple and has a good correlation with clinical outcomes as per studies available, it still holds good now. But there are various limitations of the ejection fraction. From the physiological limitations, if you see, it's a load dependent. So if you have a high afterload or a decreased preload, again it changes. Difficulty in high and low heart rate. Every day we struggle with this when patient comes with bradycardia, whether it is having good ejection fraction or bad. That also is there. When patient has MR, severe MR, again you rely upon other parameters like dP by dt. When the LV cavity is small, again you are in trouble. Then there are technical considerations as in any echo image. If the image quality is not good, again it has a problem. When the geometry, the shape of the LV is not as ellipsoid or the prolate ellipsoid type, again there is problems. Then you have the arrhythmias and LBBB. So this all adds to the problems with ejection fraction as an ultimate. But as of now, ejection fraction is in all guidelines, and it is based on heart failure classification. Everything is based on ejection fraction as of now. So when you go for another parameter, it should be better or at least as equal and good as this. So another parameter that has brought in a strain, that is fractional change in the length of a myocardial segment relative to its baseline length. And it is by speckle tracking imaging that it's done. And it's seen that it's more sensitive than ejection fraction in mild LV dysfunction patients, especially in chemotherapy-related cardiotoxicity. And it has been shown to studies to diagnose and exclude coronary artery disease. It's better than LV ejection fraction and has shown to be more reproducible when compared to LV ejection fraction. But the disadvantages of strain still is there. It depends on the image quality. There is vendor variability when it started off first as strain rate imagings, and the temporal resolution limitations still stay off. Another parameter that has come and is an extension or a variant of strain imaging is called the myocardial work. And a lot of studies are going on in this area, that it combines the LV strain with an estimate of LV pressure. So an estimate of LV pressure simply in terms of taking the cuff blood pressure of the patient and adding it as a measure on afterload. So the loading conditions also taken into this EF parameter. So that is where this was studied by Dr. Sugo for global LV function, and Dr. Tyberg was the one who studied it in a regional LV function way back in 1960s. But when a similar method using the cuff blood pressure was shown, it has now been studied more. And this has come in two articles in 2012, where this has come into existence, that the myocardial work. So the protocol is first to measure the cuff blood pressure using and ensuring that the patient is in the same position during the image acquisition. And this step is crucial because the systolic blood pressure is used as an estimate of the peak LV pressures if there is no aortic stenosis or no LV outflow obstruction. The second sequence is to acquire all the apical views, that is the 4-chamber, 2-chamber and 3-chamber views. Go for the GLS analysis of this, and then this is vendor specific. As I know, it is only for the GE machines this protocol is available as of now. I'm not sure about that. And then if you enter the values into that, you get this myocardial work index. So 4 components are shown, that is a global work index, global constructive work, global wasted work and global work efficiency. The global work index is from the mitral valve closing to the mitral valve opening. If you see to the figure, it is the A part, the B part and the C part of the pressure loop added together, which makes the global work index. Similarly, you have a constructive work where the wasted work is taken off and only the constructed work, that is the aortic valve opening to the mitral valve opening, and the graph is taken. And then you have a component called the wasted work where only the components the B and C are added up. So that is from the aortic valve opening to the mitral valve opening. This all is, when you enter it in the software, it comes out. So you don't have to go through it in detail. Then there is a term called the global work efficiency. The advantages of the myocardial work is that it incorporates the afterload, which is a major deficit of the EF as a criteria now. And it uses strain values from the entire systole from the onset of contraction to the onset of LV filling, and it's not a snapshot as such. And it includes a measure of mechanical efficiency and therefore provides a more comprehensive data. The unit is millimeters of mercury percentage. And the pitfalls is that it again assumes that the LV wall thickness is equal, the entire, it is uniformly disturbed, the pressure is uniformly disturbed, and the peak LV systolic pressure is assumed to be equal to the arterial blood pressure if there is no aortic stenosis or LV outflow obstruction. But finally, is it the time to end the LVF criteria? My personal opinion is that as of now, we don't have a robust criteria to say that it is the end of the LV ejection fraction as a criteria. You need more studies and more prospective data before we move on to strain and or the myocardial works as an index. As in all fields, the artificial intelligence has also taken up, and now even a snapshot of the LV can give you the ejection fraction. So technology is advancing and maybe LV ejection fraction will still hold on, but it has its own inherent limitations, including the low sensitivity and load dependency. You have various components of the myocardial work like the index, efficiency, and constructive and wasted work if you take the myocardial work, and further testing is needed. Thank you all.
Thank you, Dr. Prameen. Next, we go to the 6-minute walk test, underused tool for daily practice. Dr. Joby K. Thomas.
Good morning, teachers and chairpersons, friends and colleagues. So I'll be talking about 6-minute walk test. It's a simple clinical tool which I haven't used before I was given this topic, and I assume most of us haven't used this test. So I will take you across this topic for next 6 minutes or so, talking about its usefulness and its limitations. So coming to its history, the earliest reference of the 6-minute walk test comes from Bach and Warr in 1959, and they developed a treadmill test to assess the physical fitness in healthy individuals. Later, researchers used 6-minute walk test and 12-minute walking test in a cardiac and pulmonary patients as they better reflect their daily activities. And those are standardized for almost 4 decades. And in 2002, the American Thoracic Society standardized the protocols for 6-minute walk test. Why is it important? It's simple, it's inexpensive, and it represents the daily activities for most patients and healthy individuals. And it's well tolerated by heart failure patients, COPD patients, ILD patients, and pulmonary hypertension patients. and it assesses the submaximal exercise tolerance. And its clinical implications, it can be used to monitor the disease progression in COPD patients and pulmonary hypertension patients. And it can assess the functional capacity in heart failure patients, both heart failure with preserved EF and reduced EF. And it can assess the frailty in elderly patients and hospitalized patients. And this topic might be important because of late, most trials use the 6-minute walk test as a secondary endpoint. We have data on the 6-minute walk test from preserved HF trial where DAPA was used. And again, determined, reduced, and preserved trials, again, DAPA was used. And it's all trial, seniors trial also, which used Nebula also use the 6-minute walk test as a secondary endpoint. And fair heart failure and confirmed heart failure trial, when iron was used in heart failure therapy, was also had used 6-minute walk test as a secondary endpoint. And we have also data from other trials like REHAB-HF, Summit trials, and STRIDE. And how do we do it? We need certain requirements, like we need a 30-meter flat straight corridor, which most of our hospitals have, and we need a stopwatch to count 6 minutes, and lab counter to see how many laps the patient has walked, and a measuring tape, pulse oximeter, a BP monitor, a defibrillator just in case patient arrests or so, and oxygen therapy, and maybe a chair for rest in between. And patients who has had a recent MI with severe elevated suction might be contraindications, but most MI patients with reasonable EF can have this test before discharge. And any resting tachycardia more than 120 or high BP is a contraindications. So is uncontrolled apneas. And doing it, we need to ensure comfortable clothing for the patient and avoid heavy meals and caffeine before the test, and record baseline vitals and oxygen saturations. And patient may be asked to walk back and forth between the marker endpoints, which is almost 30 meters, and patient can rest if needed in between. But this timer continues in between even if you take the rest. So the exact 6 minutes is recorded. This is one of our patients which we had done recently. This patient's BP is being monitored and also his saturation. This is our physio doing the test. And this is our hospital corridor where we make our patients walk for the 6 minutes. And I have done, as I told, I have done this a few cases only after this talk was given, but our surgical colleague does this on a regular basis. This is our surgical floor where patients is made to walk for 6 minutes. And mostly it's patient is accompanied by our physiotherapist. And they record the vitals, BPs, and saturations. And we have to have a post-data assessment of heart rate, saturation, and box scale for dizziness, fatigue, and dyspnea. Maybe the vitals like BP after 2 minutes. And the total distance has to be calculated, the total labs and the partial distance. And notice stops in between as well. And how to interpret this test? Healthy individuals mostly can walk for more than 500 meters, up to 700 meters in 6 minutes. Lower distance shows impaired functional capacity. And in follow-ups, a more than 50-meter increase shows the improvement in patients, shows a clinically meaningful improvement in patients' functional capacity, and can track the disease progression or treatment response as well. And there's no standardized protocols for the distance, based on distance from ATS guidelines, but based on consensus from multiple trials, COPD patient has to have to walk for at least 350 meters, and anything less shows a high risk for rehospitalization. And for heart failure patients, the cutoff is almost 300 meters, and patients walking less than 300 meters in 6 minutes is linked to increased mortality and rehospitalization. And the pulmonary hypertension patients walking for less than 250 meters is associated with poor prognosis and survival. And coming to its advantages, it's simple, it's inexpensive, and reflects daily activities. And it is sensitive to small changes in the heart failure and rehabilitation, and we can assess the improvement on follow-up checkups as well. And coming to its limitations, it needs standardizations for reliability. As of now, we don't have the distance standardized, only consensus. And it's not suited for patients with severe mobility issues and patients with high functional capacity where there can be ceiling effect. And summarizing, this is a valuable tool to assess the functional capacity. is widely used in cardiology trials, so we need to be aware about this. And it's simple to perform, and its integration with wearable watches and technology maybe for real world data can help in future. Thank you.
Thank you, Dr. Joby. I think we'll go on to each topic. Intensive lipid lowering by Dr. Jayaprakash. One question is, if the baseline is very low, like at least some patients have total cholesterol of around 100. So what is your approach? And sometimes it is very difficult to convince these patients also.
Yeah, I would say baseline LDL being low, it may be very difficult to bring down to the set targets. Because in most of the trials, they had included patients above 55 LDL. So if there is no much data to start on a treatment, or I mean, to bring down further in a patient less than 55, that may be extremely difficult to bring down also. But still, in that few trials, the patients who are less than 55 were brought down to 20 or even to 10 was possible with the combination of high-dose statins, 80 milligrams, or rosuvastatin, or 40 rosua plus acetamide, plus bempedoic acid, plus PCSK9.
Inside.
Jabra,
One question to Jayaprakash sir. Is there an indication for parenteral lipid lowering at the first admission?
Parenteral?
Lipid lowering drugs. Role at the first admission.
Without starting statins.
The patient already started acute MI coming. Patient is not so far not received any medications. They started on statins. Is there any role for intravenous or parenteral therapy?
Patient not on statin, you are telling.
Acute MI.
Acute MI patient not on statin.
Not.
I don't think there is much data to start directly on PCSK9 or things. We have to go with 80 milligrams of atorvastatin plus acetamide. That is the hit early trial has shown that 80 milligrams of atorvastatin plus acetamide within 24 hours of an ACS. If that is not after our assessment 4 weeks, 8 weeks, it is not coming, then bempedoic acid plus PCSK9 may be a choice.
Jabraj, along with the statin therapy, should we also look into anti-inflammatory markers, or is it only the lipids which push on to the severity or the risk factors?
See, statins and the other, the markers, rosuvastatin, etc., had some trials right from the Jupiter trial to bring down the CRP and other markers. But as such, there is no definite data to look for the other markers, because LDL is one of the markers, surrogate markers, which has got good data. And other markers like all our other markers, ERP, that lipoprotein and little a, ApoB, all these has lesser data compared to the LDL.
Any questions from the floor? We'll go to the next topic. This is ticagrelor monotherapy. We know that long-term aspirin produces bleeding, but when to stop aspirin, especially in acute MI settings? You have already gone through that, but just for...
Yes, sir. Actually, the two major trials which gave us the insights are from the Ultimate DAPT is the latest one, but that is only 1 month duration. The STEMI was included. But the more global trial, that's a Chinese-based trial. The other thing is a more global trial. That is the Twilight ACS trial, where the data is first 3 months of DAPT followed by long-term ticagrelor monotherapy. So if you are really forced to cut short, 1 month is okay if you're using the latest generation stents. But the only limitation that study that we have is ethnicity is 80% of patients were from the Chinese population.
Not an acute MI also. Acute MI.
Acute MI was included in both the other trials, sir. Both the TICO and the Ultimate DAPT, it was included, but excluded, STEMI was excluded in the Twilight, sir.
Any other questions from chairpersons?
Yes. Yes, sir. Leaders, again, it was a mixed population. It seemed to be the criticism of the trial was that the high risk and the mixed groups were there. There, the endpoints did not show superiority in the stable subset, the non-ACS. The ACS arm still got the benefit with the shorter DAPT, sir. Yes. Yes. As per the Ultimate DAPT, the last one, which is that trial is only there to justify that action. But by and large, looking at the evolution of 10 platforms, the guidelines are moving towards the highest bleeding risk group. Definitely, we do not shy away with this 1 month of TAP, more than sufficient in most of the cases. But if the thrombotic risk is too high, left main bifurcation, complex, very complex substrate, 3 months would be ideal, taking from the global information that we have from Twilight. But only caveat being, Twilight excluded STEMI per se. But you have ACS and unstable angina and the usual substrates also. That's the global leaders was a trial which was a relatively negative, neutral kind of, and it did show benefit only in the ACS arm, not in the stable substrates of the spectrum of disease. The bleeding was not seemed to be higher. That was the issue in that trial. So the ischemic benefit was preserved all over. Bleeding was not that high to justify this strategy, as per the global leaders. I didn't put it there to avoid the confusion. Thank you.
I think all patient practice, including procedures, stents, everything has to be taken into consideration before you cut short to the
Probably the
therapy.
TAP score kind of. Thanks.
Any questions from the floor? Then we'll go to the next LV function assessment, time to end LV EF criteria. We all know that EF is a volumetric index, and it may not really reflect the LV function, especially the EF is not much dependable for longitudinal fiber shortening. That strain may have a higher value, but do you have a better index now? I don't. We have to discuss. And especially, do we have any specific criteria on strain, like EF 40 and all, EF 50? We have different criteria for any surgery and all. But for strain, do we have say criteria like that?
I think in the other ischemic heart disease, we don't have a criteria, but in the chemotherapy related dysfunction, we have a criteria.
For MR, AR, and AS, no, there may be latent LV dysfunction, which could be assessed by strain. But do you have a criteria for a sir?
Criteria as such is not there. So that is a problem.
Any questions from the chair, please? Any questions from the floor?
Respected dignitaries, to keep a tab on the time, I request you to please wind up the discussions.
But
As
one
soon as
question
possible.
for the last 6-minute walk test. Anybody wants to? I think the only comment was that 6-minute walk test. It is not an organ specific test. That is the only limitation possibly. So I think in view of the time, we'll cut short, stop this section, and thank all speakers for their talk.
We extend our heartfelt thanks to our speakers and session chairs, Dr. C.G. Sajeev, Dr. Philippos John, Dr. Manikantan TV, Dr. Sadat Pareed, and Dr. Iqbal PT. Thank you so much.